Ashish, Vice President with Zydus. And at the outset, I thank Mumbai Hematology Group for giving Zydus this opportunity to collaborate for today's webinar on new insights into the treatment of Hodgkin's lymphoma. While COVID keep coming back and India is again seeing a rise, but thanks to MHG and Dr. M. Agarwal, where we have platform like this, which gives the opportunity to have the expert from across the globe to connect with as many clinicians helping improve outcomes. And today I welcome our eminent guest speaker, Dr. Joseph M. Connors, who have joined us from Vancouver, Canada. Dr. M. Agarwal would be introducing him. I would also warmly welcome our eminent faculty members who have joined us from almost every part of India, and will be discussing with Dr. Connors on improving outcomes on Hodgkin's lymphoma post his session. I also welcome virtual delegates who have joined us for today's webinar from not just India, but across the globe. Now, a special welcome to the person who has got everyone together for today's webinar and made the biggest use of digital platform by initiating this what we call as virtual hematology university, where we have expert almost every week since last 2 years to share the knowledge with everyone who is keen to learn. Professor Dr. M. Agarwal, he will also moderate today's session. I have the privilege today to introduce him. Sir is presently the head of Department of Hematology at Bombay Hospital Institute of Medical Sciences in Mumbai, and also the director of Mumbai Hematology Center located at Dadar. He also acts as a consultant hematologist at a number of hospitals in Mumbai, including the Leelavati Hospital in Breach Candy. Sir has held a number of important positions, some of which are past president Indian Society of Hematology and Transfusion Medicine, president Mumbai Hematology Group, and also at the Selection Committee Department of Pathology at the Tata Memorial Hospital, Mumbai. A career spanned over 4 decades has not just helped patients in India get better, but he has also inspired many young clinicians to take up hematology and has always taken the lead to disseminate the hematology update by bringing the eminent and expert group together like we have the eminent Dr. Connors today. Thank you, sir, for all your efforts, and over to you.
Thank you, Mr. Ashish, for those kind words. Good evening to everyone in India. Good morning and good afternoon in the remaining part of the world. Today, our guest speaker is Dr. Joseph Connors from Canada. He will be lecturing on new insights into the treatment of Hodgkin lymphoma. Most of you were fortunate enough to listen to him about 6 months ago, and he will be taking over from where he left last time. This webinar is brought to you as usual by Mumbai Hematology Group. It is supported by Zydus and managed by Perfect Square. I thank Mr. Ashish Kumar and their team from Zydus, Mr. Yash Kalpesh and their team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Joseph Connors from Canada, all our discussants who are themselves extremely important and eminent hematologists and medical oncologists from various parts of India, and you participants for sparing your Saturday evening, morning or afternoon. Today we have registrations over 350 from 25 or 27 countries. And they are not only from Asia, but also from various parts of Europe, Australia, South America, America itself, and Canada. Just to introduce you to tomorrow morning activity, we have Dr. Professor Sharat Damoda from Bangalore speaking to us on challenging of setting up a bone marrow transplant unit in low middle income countries, and that will be at 11:30 a.m. In the beginning of July, that is from 4th to 10th of July, Monday to Sunday, every evening, 3 hours. This is Indian Standard Time, 6:30 p.m. to 9:30 p.m. We have a week-long webinar, Challenges in Hematology, which includes the best of EHA, which was conducted just a week ago. We have 21 international speakers, 3 every day. So just see to it that you are free by 6:30 p.m. IST and join us to listen to these giants in their fields. Today's discussants, and we have, as I said, galaxy of them, Dr. Abhishek Dudatra from Ahmedabad, Dr. Aditi Jain from New Delhi, Dr. Aditi Tanki from Rajkot, Dr. Afaq Ahmed Khan from Srinagar, Jammu and Kashmir, Dr. Aishwarya Raj from Ahmedabad, Dr. Akshaya Mandole from Kolkata, Dr. Dipti Rani Samanta from Cuttack, Dr. Gunjan Prasad from Kolkata, Dr. Harveen Busari from Nagpur, Dr. Radhika KK from Hyderabad, Dr. Mobin Paul from Kochi, Dr. Mona Vijayaran from New Delhi, Dr. Nakul Tikare from Bhubaneswar, Dr. Parinitha Butha from Hyderabad, Dr. Rima Miria Ibrahim from New Delhi, Dr. Ria Balikar from Nagpur, Dr. Sweta Lankat from Pune. And now, to reintroduce Dr. Joseph Connors to you. I'm extremely grateful to him for getting up so early in the morning. It is just about 6:30 in Vancouver, and he has accepted our invitation for the second time during this pandemic. All of you know him. He's a huge name in the field of Hodgkin lymphoma and lymphoma in general. A lot of you have been exposed to his readings, his research, and listening to him. To complete the formalities, he is clinical professor, Department of Medicine, Division of Medical Oncology, University of British Columbia, Vancouver. He received his MD from the Yale University, and he did his internal medicine residency program, training, and chief residency at the University of North Carolina in Chapel Hill. He then worked in the Indian Health Service in Alaska for 2 years before completing his medical oncology fellowship at Stanford under Dr. Rosenberg. He accepted a position in medical oncology at the BC Cancer Agency in 1981 and has been a member of the Faculty of Medicine at the University of British Columbia since that time, reaching the position of clinical professor in 1997. Presently, he is a clinical professor in the Department of Medicine, Division of Medical Oncology at the University of British Columbia, and the chair of the Lymphoma Tumor Group for the British Columbia Cancer Agency, and focuses his clinical activities and research efforts in the area of understanding lymphoid cancers. He is recognized both nationally and internationally for his work in the field of lymphoma. He's published over 450 peer-reviewed scientific articles addressing various aspects of research into lymphoid cancers. He's been awarded the Terry Fox Cancer Research Award by the British Columbia Medical Association, the Bernard Schwartz Memorial Award by the Scrippi Health System in San Diego, California, the Canadian Cancer Society John Wittig Memorial Award by the Medical Association, Karl Muschoff Award of the German Hodgkin Lymphoma Study Group, Cologne, Germany. A fierce patient advocate, Dr. Connors has touched the lives of countless lymphoma patients and trained scores of hematologists who are sharing their knowledge to benefit patients across the country as well as internationally. I'm really privileged today to invite him to give his lecture on new insights into the treatment of Hodgkin lymphoma. Hodgkin lymphoma is a complicated subject. Every time you feel that you have probably achieved everything, you realize how difficult it is. And though highly curable, you still see patients dying in front of you. And this complicated subject will be simplified with all the advances today by Sir. So over to him.
Okay, so I'm going to share my screen, and thank you very much for the invitation to share these new insights into the treatment of Hodgkin lymphoma. I'm delighted to do so because the field does continue to change and shift over time. Here are my disclosures. I might be discussing off-label use of various drugs, including brentuximab vedotin, the checkpoint inhibitors nivolumab or pembrolizumab, a yet-to-be fully named compound AFN13, camidanlimab tesirine, everolimus, and itacitinib, different kinds of drugs that are being brought into the field. So I've divided the talk into sections. At the beginning, I'm going to talk about the primary treatment for advanced Hodgkin lymphoma. In this area, I think the new insights are ready for integration into our current care. And so I think these are the parts that are ones that you can apply at the moment. I'll be eventually addressing relapsed refractory Hodgkin lymphoma, alternatives that are in the process of being demonstrated to be helpful in the situation where primary care hasn't been successful. And finally, a section in which I mention a number of evolving or new developments that are occurring these are not ready yet for implementation into full care, but rather I wanted to alert you to some of the new approaches that are being found to be effective in this disease, as you can watch their further integration into the field with future publications. So to begin with, we'll go ahead and a bit of review. For some time now, the 4-drug combination of ABVD, adriamycin or doxorubicin, bleomycin, vinblastine, and dacarbazine has been the standard for the treatment of advanced stage Hodgkin lymphoma. The largest attempt to switch away from that to something better that occurred in recent years was the regimen called Stanford 5, devised by the group at Stanford University, but eventually tested in a United Kingdom-wide lymphoma study group study. I'll briefly remind you that Stanford 5 was different in that chemotherapy was given every week. There was the mixture of old drugs, doxorubicin, vinblastine, and others, an even older drug, meclorethamine, and integration of new drugs like etoposide. And growth factors were used to stimulate the production of neutrophils throughout the treatment. This was complemented by radiotherapy. The fields were defined based on original lymph nodes and residual masses, and there were some special modifications to try to minimize the potential toxicity of radiation while taking advantage of its effectiveness. The randomized trial directly compared ABVD with Stanford 5, and jumping to the bottom line, it turned out that ABVD was equal in performance to Stanford 5, and this, despite all of the effort that was put into devising the new regimen, it wasn't a step forward. And you can see here the progression-free survival and overall survival curves. And so this attempt to bring things forward didn't wind up being able to alter the field. The next one to remind you of is one you've heard about many times over the years, and that's escalated BIACOP, devised by the German Hodgkin Study Group. And there were 3 special characteristics of this regimen that distinguished it. First of all, it was intensified, and so a new drug was added, etoposide, and some of the drug doses were increased, making this a harsher and potentially more effective drug. It was also intensified by being given more frequently on 3-week cycles rather than 4-week cycles. And once again, the assistance of neutrophil growth factor was necessary throughout the treatment. Ultimately, this regimen was tested very thoroughly, initially by the Germans and then by other international groups. At first, it did appear as though this was a genuine step forward, and there seemed to be an improvement in overall survival in the long-term follow-up of these patients. But notice that that initial comparison was with the combination of COP-ABVD, not a straightforward test against the drug group I'm calling the standard, ABVD. Ultimately, the other groups with their prospective randomized trials were unable to demonstrate that the ultimate outcome for patients, overall survival, could be altered in the long run by this intensified regimen. And it was somewhat unpopular because of its level of toxicity, making it impractical or dangerous to give to patients over the age of 60, and resulting in extensive hospitalizations and other complications during its delivery. And so the most recent attempt to change things was built around the antibody-drug conjugate brentuximab vedotin. You'll recall the mechanism whereby the antibody-drug conjugate binds to CD30, it's internalized into the cell, the complex molecule is dissolved in lysozymes, and it releases the microtubular disrupting agent, monomethyl auristatin E, which breaks up the microtubular structure of the target cell. And this also may potentially result in the immunogenic release of different cellular components to inspire an intensified immunologic reaction to the malignant cells expressing the CD30. This was initially tested as a single agent in relapsed patients, and the important thing to see in this was emerged with the long-term follow-up of the initial phase 2 study. And what I'm highlighting here is this tail on the curve. There are only about 100 patients in the trial, but of those, 13 of them remained in remission from a single agent despite their multiple relapses of disease for long periods of follow-up. Some of these patients had undergone transplantation, but some of them had not received anything further at all. What this is important for is the demonstration that despite failure of ABVD and high-dose chemotherapy, a small number of patients may have been cured by the single agent. Enough promise for us to bring it forward into a large prospective randomized trial. Once again, you've heard of this trial, the Echelon-1 trial previously, when it was noted that it improved the progression-free survival in patients. But what's a new insight today, and just recently emerged and presented at the ASCO meeting a few weeks ago, was the comparison looking at the outcome of overall survival. So it was a 1-to-1 randomization, brentuximab plus AVD compared with ABVD, given for standard 6 cycles, and then the patients followed for long-term outcome. The key secondary endpoint I'm going to focus on is the overall survival. The balance of the arms of the trial was maintained, and the patients were randomized properly, in large numbers of patients, more than 1,300 patients enrolled. And as you can see, glancing down these numbers here in the 2 columns, the representation of different stages, ultimate stages of stage 3 and stage 4 patients was balanced between the 2 arms of the trial. The progression-free survival we previously had demonstrated was superior with the experimental arm. But as has happened in many times, the capacity to rescue patients that have relapsed after primary therapy often brings about trials that equalize the overall survival with the long-term follow-up. In this case, when we jump to what was resulted from in the Echelon-1 trial, although both groups of patients, those on the experimental and those on the control arm, did very well overall, you can see here that the experimental arm ultimately resulted in an improved overall survival compared to that of what was achieved with ABVD. It seems like a relatively small difference, but with so many patients doing well with the control arm, reducing or improving survival, even this modest amount, is a reduction by 41% of the risk of death, and indicates that we finally made a step forward and have at hand, if you like, a regimen that can bring about the cure of more patients with advanced stage Hodgkin lymphoma than with the regimen we've been so relying on for the past 3 decades. The benefit was shared here on these forest plots. The thing to notice with your eye is that the solid square dot is most often to the left in favor of the experimental arm for the various subgroups of patients, regardless of age, regardless of area of the world in which the patients were treated, the international prognostic factor scores, and the other characteristics of the patients, indicating that the benefit was shared widely across patients with advanced stage disease. There were fewer patients that died from Hodgkin lymphoma or disease or treatment-related complications. Comparison across the 2 columns is best seen by simply looking at the top number there. The total number of deaths was fewer on the experimental arm, hence the superiority in terms of overall survival. And the patients subsequently required less treatment because of failure of their primary regimen. And the difference in the 2 arms of the trial emerged despite the fact that brentuximab vedotin was available for secondary treatment for patients that relapsed on the control arm. Excuse me. So what the escalated BIACOP regimen had run afoul of was the challenge that it wound up inducing more toxicity for patients, such as the long-term toxicity of secondary malignancies. And so it was important in the Echelon-1 trial for us to compare the experimental arm versus the ABVD. And you can see here that there were fewer secondary malignancies reported in the experimental arm. Notice that the difference is in the top, the lighter colored areas up here, I think oops, I didn't want to do that. Let's see. If I use my pointer here, you can see it's a smaller number of these secondary malignancies here. Those are the hematologic malignancies, because of course, with only 6 to 10 years of follow-up, we're not yet seeing any changes in solid tumors. But it does look as though the use of the more curative treatment, the experimental arm, was capable of avoiding some of these secondary deaths from secondary malignancies. We also have to focus on fertility, and an indirect measure was used in simply counting up the number of successful pregnancies seen in the patients or their partners in the patients enrolled on the trial. And here, there were the same number of pregnancies in each of the two arms. And then finally, the toxicity of peripheral neuropathy, because the combination of brentuximab and vinblastine in the experimental arm did result in more peripheral neuropathy being generated. But if we jump right to the bottom line here, with long-term follow-up, very few of the patients are left with symptomatic problems with peripheral neuropathy, remembering that grade 1 peripheral neuropathy is asymptomatic. The very small numbers with persistent neuropathy on either arm of the trial indicates that this is acceptable and tolerable for patients. And so I think we can conclude that we do finally have our hands on a regimen which has shown a genuine statistically significant improvement in overall survival. And it makes this an attractive regimen to use for patients with advanced stage Hodgkin lymphoma, and the one that we will be able to compare things to in the future, as I'll be speaking to in just a moment. So what about other ways of making things better? Well, it's a whole topic unto itself to talk about attempting to use PET guidance during the course of treatment to improve the outcome for patients. I'm going to just discuss one single trial here, which did attempt to do this and demonstrate, I think, what one gains by using PET guidance. But it's different from curing more patients. What it is, it's a strategy to reduce toxicity. And so we'll look at this complicated trial, the AHL 2011 phase 3 trial from LYSA. The structure is complicated, but it boils down to a comparison of standard treatment versus PET-driven treatment. So if we look across the control arm of the trial, before I do that, I have to remind you that in this particular trial, a definition for PET2 or interim PET scanning being positive was changed from what the usual one that we use. And it was considered negative if the patient had a Duvel score of 1, 2, 3, or 4, where the SUV is less than 140% of the uptake in the liver, a more exacting definition that would therefore more broadly define patients as having had a negative PET scan. If we go across the top here, you can see that the patients on the standard arm start out with BIACOP, but remain on escalated BIACOP throughout their entire treatment. So all of the patients received escalated BIACOP throughout their entire course of treatment. The experimental arm relied on the interim PET to sort patients out. And if it became negative using this special definition, the patient was put on a de-escalated regimen, dropped back to standard ABVD. This was available to about 85% of the patients who had become PET negative using that special definition. And in this case, only a small minority of the patients require the BIACOP be administered all the way across the trial. Ultimately, the progression-free survival was exactly the same in each of the two approaches. So what this demonstrates is that you can use PET guidance to improve the treatment of these patients, but the improvement is not one in which more patients are cured. It's an improvement in which there's less toxicity. That is, fewer of the patients have to take the escalated regimen all the way throughout their treatment. The curves demonstrate just how precisely the two approaches mimicked each other, and you can see experimental and standard arms are indistinguishable here in terms of progression-free survival. It did make a difference, of course, if you were PET2 positive, but patients could still be cured on either arm of the trial when one looks at the difference between PET2 negative at the top and PET2 positive patients who had become PET negative at 4 cycles, or those that remained PET positive through 4 cycles of treatment, and an outcome that we would have expected to see and was compatible with previous observations. So looking again at the final outcome where we had seen an overall survival difference in the Echelon 1 trial, no overall survival difference resulted here. And so a sensible conclusion is that escalated BCOP is highly effective. We knew that already, but we also know that it can be potentially quite toxic. De-escalation based on interim PET reduces toxicity but doesn't alter efficacy. So we'll continue to search now for improvements in the primary treatment of Hodgkin lymphoma, and I'll discuss a couple of possible ways that we may approach that in the future. So, of course, you're aware of the fact that the new player, the new approach to these patients that we can take is to use one of the checkpoint inhibitors. And so I'm going to talk with you about 2 phase 2 approaches that have demonstrated the potential for these agents to be used. In this one, classic Hodgkin lymphoma, stage 2 with adverse factors, or 3 or 4. The patient treated initially with nivolumab as a single agent, and then after that initial response or exposure had been completed, switched to the combination of nivolumab and AVD for at 2-week intervals through 6 cycles of treatment and then follow-up. This group of patients, modest, 51 patients, were representative of those with advanced stage Hodgkin lymphoma across the full age spectrum, international prognostic score spectrum, and disease stage spectrum. And so appropriate patients to test this new approach in. And we can look at the comparison between the investigator's assessment and the independent review committee, and there's a pretty good match here. The tops of the columns are about the same. Notice that most of the patients are having complete responses with an overall response rate in the 80% range for each of the 2 groups of each of the patients with this experimental approach. And the outcome looks very good. We were hoping to see a curve that would sail along at the 90+% range. And so that was what was achieved. But notice the time scale at the bottom. This is just a brief period of observation. This is enough to tell us that there's real potential here, but of course doesn't establish this as a new way to treat patients. There is another checkpoint inhibitor that has been widely tested. And if we now focus on pembrolizumab, the anti-PD-1 agent for this same kind of immunologic boost to treatment, similar patients with advanced stage disease, this time given a schedule of pembrolizumab at fixed dose. And rather than continuing the checkpoint inhibitor, they switched over to AVD and then followed the patients. Also a small study, just 30 patients, but you can see here that it's again the full spectrum, men and women, different ages, different stages, different IPS scores, different levels of or numbers of patients with bulky disease. And when we look at the outcome here, we get to look, what does the pembrolizumab by itself accomplish? Only a modest complete response rate. But with the continued AVD after the pembrolizumab, the complete response rate bumps up all the way to 100% in this small group of 30 patients. And as would expect in short-term follow-up, again, it's just months across the bottom, the curve is nice and flat and very high, indicating the potential. Well, why did I tell you about these 2 small studies? Well, the reason is because we're going to need to go ahead and figure out what to test next compared to the combination of brentuximab vedotin and AVD. And I think that it's quite sensible, as has been undertaken by the intergroup in North America, to test that new standard, brentuximab vedotin plus AVD, against a checkpoint inhibitor plus AVD. That trial is in progress and will eventually tell us if the checkpoint inhibitors bring about a genuine improvement beyond what's been achieved with the new regimen as tested in Echelon 1. So I'm going to shift focus then and reach back as far as the ASH meeting in 2020 to talk about other approaches to patients, first with primary treatment, but then potential uses of regimens for patients with relapsed disease. So this first of the studies is one for patients who are elderly or frail. So this is a patient population that we've been constantly searching for better recipes for. These are patients who just simply can't take our standard approach, ABVD in the past, or perhaps brentuximab vedotin plus AVD in the future. And we're looking for ways that we might treat these patients that are within the bounds that they can tolerate and are still highly effective. So in this particular study, patients with advanced stage disease over the age of 60 who are unsuitable or unfit for conventional chemotherapy, but had measurable PET-avid disease, were treated with one of 4 different approaches, brentuximab vedotin by itself, or in combination with dacarbazine, bendamustine, or nivolumab. Small numbers of patients just to test out what might be achievable. If we look at the progression-free survival curves, the performance across the different approaches were fairly similar. One is looking here for a winner, which of the approaches might look better. And perhaps with the eye of belief, one can see the green curve, the brentuximab vedotin plus a checkpoint inhibitor looks as though at least it's performing as well as anything else and possibly better. And so indicates a direction that we might take, remembering that these are patients for whom we don't have a reliable standard treatment that's within the level of toxicity that they can tolerate. The overall survival curve also demonstrates that performing as well as any of the other combinations, the brentuximab vedotin, the antibody drug conjugate, and the checkpoint inhibitor is looking like it's performing reasonably well. And so this is an approach that you can watch to be tested further in patients who are too frail for standard therapy. And we would then want to be comforted to see whether the spectrum of toxicity was acceptable for these patients. And I'm not going to review all of the numbers in the columns, but point out that if you look at the bottom of the third column, the brentuximab vedotin plus bendamustine, you see that there's a jump up in the number of patients who had to discontinue treatment because of toxicity. And so a different insight, a discouraging one, telling us that that's a potential couplet that would not be worth taking forward because it also would prove to be too toxic. And probably the best idea here is to see what can be built around the antibody drug conjugate and the checkpoint inhibitor combination. So my conclusion here is that although brentuximab vedotin monotherapy is active and tolerable, it doesn't perform as well as we would like things to in the future. Brentuximab vedotin plus bendamustine is unacceptably toxic, and the checkpoint inhibitor being added to the brentuximab looks like the active, tolerable, modestly better approach to take. And now I want you to watch for this being tested further in the future. Enough about primary therapy. For some additional new insights, I'm going to now focus on the treatment initially of relapsed refractory disease. In this case, we'll look at first occurrence. So remember then that if a patient has primary chemotherapy, usually with ABVD, but perhaps with brentuximab vedotin plus AVD in the future, some of the patients will have a relapse of their disease. And the standard here has become the use of high-dose chemotherapy and autologous stem cell transplantation. We learned in the Athera trial that complementing that with a maintenance or consolidation phase of brentuximab vedotin brings about an improvement, and some of these patients can be cured despite failure of their primary chemotherapy. This is a look at trying to improve against that particular approach. In this case, just shy of 60 patients with relapsed or refractory advanced stage Hodgkin lymphoma with risk factors of various sorts, B symptoms, early relapse, having required more than one salvage regimen before their transplant, or less than a complete response at the time of the transplant. And they were allowed in the trial if they had received brentuximab vedotin or a PD-1 inhibitor, as long as they weren't refractory to one of those agents. And the treatment was a standard autologous stem cell transplant, followed by brentuximab vedotin, the Athera trial approach, plus nivolumab, so adding a checkpoint inhibitor to the brentuximab vedotin. The adverse event spectrum was not surprising. The kinds of toxicity that one would expect from the overall treatment approach and the agents being used was as expected, and so no surprises emerged. And the outcome was particularly good. This was a relatively short follow-up of just 3 years, but that curve is quite a bit higher than we might have expected had this been the standard approach of autologous stem cell transplant and brentuximab vedotin. So of course, this is a guide to what we might eventually be able to turn to in the future. I haven't seen an update of this yet, so we would like to see a longer-term follow-up to see if that improvement is sustained. But if it is, then complementing the autologous stem cell transplant with both new agents, brentuximab vedotin and a checkpoint inhibitor, would be the way to go in the future for the patients in first relapse or first demonstration of refractory disease in Hodgkin lymphoma. So this turned out to be true regardless of the mix of risk factors that were present, and all three groups wound up with very good outcomes with this approach, indicating its continued promise. And so short-term overall survival is encouraging enough to know that this is something we should continue to test and to move forward. I'm going to jump that. So patients who have been unsuccessfully treated through 2 rounds of treatment, that is primary therapy, and then later high-dose chemotherapy and stem cell transplant, and perhaps brentuximab vedotin or brentuximab vedotin and a checkpoint inhibitor, some small number of patients eventually develop a recurrence despite this. And so as we watch the whole field of treatment in the lymphomas be transformed by the use of CAR T-cell treatments, we would like to get some sense of whether the same is going to be true for Hodgkin lymphoma. Now, much of the CAR T-cell treatment that's being tested in lymphoma is directed at common B-cell antigens such as CD19, but that's not a target that would be particularly attractive for Hodgkin lymphoma. Rather, the ubiquitous expression of CD30 is the target that the chimeric antigen receptor T cells are being targeted at. And so early exposure or early testing, again, a field to keep your eye on, but not something for integration into standard treatment yet, is CD30-directed CAR T-cell treatment for multiply relapsed patients with Hodgkin lymphoma. Overall survival looks reasonably good, relatively short follow-up. Notice this is just days across the bottom. Perhaps this is going to be a useful step forward, but when one looks whether the disease itself is being controlled, the outcome is rather disappointing. We knew that patients were not going to be universally cured or have a proper positive outcome across the board, but to see the curve dip down this low at the 1-year progression-free survival mark of just over 30% indicates that perhaps this is not going to be the same kind of step forward that its CAR T-cell treatment seems to be for diseases like diffuse large B-cell lymphoma. And so back to the drawing board here, perhaps further crafting of the CAR T-cells to further improve their effectiveness will be the way forward, but that's something that you're going to need to watch. And it doesn't look as though standard CD30-directed CAR T-cells are going to be the home run that we would have liked to have seen. And so I'm now going to switch even further away from standard treatment and talk about new ideas and new approaches that one might take. This is to alert you to things to watch for, as opposed to integrating into primary therapy today. But this is a new insights lecture, And so I thought it appropriate to talk about where we're going to be going in the future. The first of these is this compound called AFM13. So how does this work? Well, if we look at a classic Hodgkin lymphoma cell with expression of CD30 and the way the natural killer cells or cytotoxic T cells attract that malignant cell, the AFM is a bispecific antibody that binds to one antigen on the NK cell and the CD30 antigen on the target cell. This, of course, pulls the effector cell into the proximity of the target cell, and we would hope that this would then lead to NK cell-mediated Hodgkin-Reed-Sternberg cell destruction. So the effective approach is to pull immunotherapy into action against the Hodgkin lymphoma. This was tested by the Germans as a single agent with a randomization between a couple of different doses and attempts to optimize the approach for patients with multiply relapsed Hodgkin lymphoma who'd also had prior anti-PD-1 checkpoint inhibitor treatment. And when we look here, the outcome with the single agent of the AFM, the bispecific antibody, was rather modest, with the overall survival curve on the right looking okay for these multiply relapsed patients. But as was disappointing with the CAR T-cell approach, you can see that the progression-free survival estimate dips down very quickly by the time a year or a year and a half has gone by. And this didn't achieve what one might have hoped. So is there a way to improve on this? Well, the treatment was tolerable, but the low response rate and brief duration says we better do something better than just use that single agent. Well, remember what's going on here. The bispecific antibody has pulled the NK cells into proximity with the classic Hodgkin lymphoma cell so that NK cell-mediated cell destruction can go on, but the Hodgkin cell itself is frustrating this effort by elaborating surface constituents that block the activity of the NK cell, the PD-1 ligand expression. And so neutralizing, you like, if the antibody, the immunologic attack. But we've actually learned how to block that. The use of checkpoint inhibitors such as pembrolizumab can be used at this point to block the blockage, if you like, to block the Hodgkin-Reed-Sternberg cell from being able to neutralize the NK cell. And so perhaps a mixture of the AFM13 and the pembrolizumab will prove to be more effective. Well, this has been tested. Nancy Bartlett and her group have demonstrated that this does seem to induce response in quite a large percentage of the cells of the patients with multiply relapsed refractory Hodgkin lymphoma. And so there's some real promise here, but as yet, this has not been further tested and will require additional study to tell if it's going to be a particularly useful approach. Other potential experimental approaches that we're waiting to see the full publications of to see just how well they worked were also presented at that ASH meeting. And so I've brought them forward here a year and a half later to remind you of other approaches that are worth following as the literature evolves. This is another antibody drug conjugate, this time based around a different effector agent, not monomethyl auristatin E as in brentuximab vedotin, but an almost unpronounceable pyrrolobenzodiazepine type of agent coupled to the antibody. And so we can look to see how this might work. This antibody is directed not at CD30, but CD25. It delivers the complex cytotoxic agent that is going to be brought into the cell where the antibody drug conjugate is digested away, the active ingredient is mobilized, and one sees cross-linkage of DNA and cytotoxicity induced by a different mechanism than disrupting microtubules in the cell. And we can see what this might be able to accomplish in these multiply relapsed patients. small study with 51 patients with advanced stage relapsed refractory disease. These patients have had a lot of treatment, a median of 7 different treatments, 3 to as many as 20 different treatments. Prior stem cell transplant in the majority, sometimes allogeneic, but usually autologous. And they've had brentuximab vedotin and checkpoint inhibitor, and despite that, the disease has persisted. The overall response rate was very good, up in the 80% range. Complete response rate modest in the near 40% range. And it did make some of these patients eligible for another shot at attempting to get rid of their disease with an auto transplant. The toxicity is across a wide spectrum. I recommend that when this is eventually published, that you look closely at the full spectrum of the toxicity, because some of these toxicities are ones we're not used to seeing with anti-Hodgkin lymphoma agents, such as hypophosphatemia or liver toxicity expressed in enzymes. The frequency with which treatment had to be delayed was only modest, but there was the worrisome signal of patients with neurologic toxicity, something different from the peripheral neuropathy that we are used to seeing in our Hodgkin lymphoma patients when they're treated with vinca alkaloids and agents like that. But the emergence of Guillain-Barré type of toxicity is a real warning sign. And so this is not going to move forward unless ways are found to minimize the risk of that happening, or perhaps block it from happening in the future. So as you're reading about this new agent, the things to watch carefully is what is the full spectrum of toxicity and whether that blocks the drug from further development. I think it is warranted to conduct additional testing, but those caveats about toxicity will be very important as we think through how useful this might be. Another approach is to go to look at agents that have shown potential for the treatment of advanced Hodgkin lymphoma, but not really been able to move the field forward, the mTOR inhibitors, in this case, everolimus. But in combination with a different agent, as you'll see in a moment, an agent that is aimed at a different characteristic of the malignant cells. Once again, relapsed refractory classical Hodgkin lymphoma. We're going to look at a phase 1/2 investigator-initiated trial and see what this can accomplish. So we've got everolimus, an mTOR inhibitor, and itacitinib, a JAK2 inhibitor. This is going to focus on the PI3 kinase pathway within the cell and see if the combination might be potentially effective in patients who either were ineligible for autotransplant or have a failure of their disease after exposure to an autotransplant. One attractive aspect of this combination is that it's entirely oral. Patients are rather tired of injections by the time they get to this point in the management of their disease, and would find the use of oral agents an attractive approach as an alternative if it's going to be able to control their disease. What did this accomplish? Well, we only have a small study. Again, I'm waiting to see the full publication of this information, but this is what we learned from the ASH meeting. Advanced stage disease, lots of prior treatment, prior stem cell transplant of one sort or another in the large majority of patients, even some who had had CAR T cell treatment, and near universal use of brentuximab vedotin and checkpoint inhibitors in these patients. And the adverse event toxicity profile proved to be recognizable, but manageable. You can see once again some novel toxicities that we're not used to seeing so much in Hodgkin lymphoma management, hypercholesterolemia, and the liver enzyme abnormalities. But there were no dose-limiting toxicities encountered or deaths, and none of the patients had to discontinue due to toxicity. Of course, the discontinuation was due to failure of the treatment. They were able to settle on a phase 2 dose and bring it forward, and have a promising overall response rate, but only a modest complete response rate. So Short-term follow-up only presented in abstract form. We're waiting for the full publication of the results. But again, it's something to keep your eye on as we're watching for new approaches that might emerge. So I'm going to stop there and see what sort of questions you have. But I think what I've been able to share with you is the fact that as we try to move forward in the primary treatment of advanced Hodgkin lymphoma, PET-guided treatment has proven to be useful, but remember this reduces toxicity. It doesn't improve the likelihood of curing the patients. Checkpoint inhibitors and standard chemotherapy is quite promising, needs to be tested in proper phase 3 trials, and the comparison there needs to be against the new standard of brentuximab vedotin in combination with standard agents AVD. And finally, use of brentuximab vedotin, which is already established as a complement for the use of in high-dose chemotherapy and stem cell transplant for relapsed patients, may have continued impact on the patients who are elderly and frail and require alternative regimens, but even better regimens than we've come up with yet need to be explored. Relapsed refractory disease, perhaps combining brentuximab vedotin and a checkpoint inhibitor is a way to make a further improvement. We need confirmation with longer-term follow-up. And in relapsed refractory disease, it looks as though CAR T-cell treatment is not going to be the kind of approach that we had hoped it might be based on the outcome in aggressive histology B-cell lymphomas. There's real potential in a bispecific antibody if combined with a checkpoint inhibitor. And experimental agents like the camidanlimab tesirine and the combination of everolimus and itacitinib are worth further exploration. So those are my thoughts about new insights that are unfolding in the area of the treatment of Hodgkin lymphoma. I'm going to stop here, and I'd be happy to entertain questions about any of the things that I've said, or if there are other aspects about Hodgkin lymphoma that you wish I had said something about but didn't get to in the lecture, I'm happy to come back to that. So I'll turn it back over to Dr. Agarwal and the moderators to give me some guidance as to where you want to go from here.
First of all, thank you so much, sir, for updating us. It was a lovely lecture, learned a lot. So we have a lot of our colleagues over here. They would like to ask you something, discuss with you. I will request them to open their videos and put up the raised hand sign. I have one question for you, sir.
Sure.
A plus AVD is an expensive modality of treatment. So would you say that you will use that for a certain specific group as against ABVD, or it uniformly replaces ABVD?
Well, I think that the answer has to give some acknowledgement to the aspect that you mentioned, the expense. And so treatment with ABVD is straightforward. We're very used to doing it. We've been doing it for many years. We know how to manage the toxicity. It does bring about very good results. And so in situations where the challenges, the financial challenges of making additional agents available are substantial, it may remain the best choice. If, however, one has recourse to the financial resources that allow you to add the agent, then I would think that the addition of brentuximab vedotin to AVD would be best considered the new standard. The improvement is challenging because, as I showed you with those curves, the patients are already doing very well. We're talking about them doing even better than that. There is a reduction in the likelihood of dying from the disease or complications of the treatment of the disease. And this is ultimately the aspect of treatment that is most important to patients. So I guess the best answer I can give you is if the financial constraints will permit the use or the addition of the brentuximab vedotin, it would be my first choice for any patient with advanced stage disease. If the financial obstacles are insurmountable, fortunately, we still have a reasonably good standard arm to turn to using a regimen that we've all grown quite used to over the years.
Thank you, sir. That was very satisfying. One more question from me is about the first relapsed situation. After the autologous transplant, using BV plus nivolumab, we give BV for about a year. What about nivolumab duration?
Well, I guess I'll make a couple of comments here because, first of all, back to your first question, we're talking about an expensive approach, a high-dose chemotherapy and a stem cell transplant, making it more expensive by consolidating with brentuximab vedotin, and making it even more expensive by adding a checkpoint inhibitor. So financial constraints are likely to weigh in here also. And I'll have to give you the same answer. If they can be overcome, then I would think one certainly should be using the brentuximab vedotin. And there's real promise that might be found with, if we get further follow-up that confirms it, with the addition of a checkpoint inhibitor. I've never been much of a fan of indefinite or prolonged treatment for potentially curable diseases. What I would like would be studies that showed me how many doses are necessary and just give that number of doses. We have a hint here from the Athera trial and other experience with brentuximab vedotin. Although the plan was to deliver 16 doses, the actual delivery of the brentuximab in the trial was a median of only 10 doses. And so rather than treating to a fixed number, I think the best strategy when one is employing the brentuximab vedotin is to treat as long as the level of toxicity remains acceptable. And acknowledge that that means that the patients are often going to fall short of the full planned 16 doses and will be leaving off considerably earlier. But even when one does that, it's reasonable to expect that there's a substantial reduction in failure of the treatment. I don't have equivalent amount of or data with regard to the duration of the checkpoint inhibitor. Personally, I think one will have achieved almost everything you're going to achieve by the time the brentuximab vedotin itself is being stopped. And so I would have to say that it's going to now be the art of treatment as opposed to data-driven treatment. But to say that I would probably be happy if the checkpoint inhibitor was delivered for about a year. That I think is going to accomplish all that it can in terms of being able to cure the disease. Perhaps giving more beyond that point in time would delay an inevitable relapse that's going to occur. But I don't have data in hand to tell me that there's a superior approach to continuing either indefinitely or beyond a year's point in time once the checkpoint inhibitor has been begun.
Thank you, sir. So we'll begin with our discussions here. Dr. Aishwarya Raj.
Thank you, sir. Thank you for the wonderful update. Just wanted to know like your comments or your experience with the checkpoint inhibitors upfront in patients who don't want to go for any sort of chemotherapy in early stage Hodgkin's disease.
Okay, so I didn't actually have much to say, or I had nothing to say about limited stage disease. And I purposely didn't because I didn't think that anything particularly new had come along. What you're asking me about would be very new. That is using a checkpoint inhibitor instead of standard treatment. Is that what you're asking about?
If some patients, they are like really scared of chemotherapy and its related toxicities. So in those subset of patients.
Well, I would be very reluctant to yield, if you like, to the patient's preference there, because I would have to point out to them that instead of a treatment with a very high likelihood of curing their disease within quite acceptable bounds of toxicity, that a choice such as switching away and using only a checkpoint inhibitor would be quite experimental. Perhaps that would cure some of these patients. I don't think that it would cure anywhere near enough of them to be justified. If we ever have any data along those lines, I doubt if we will, because I don't think that's a test that investigators or pharmaceutical companies would find particularly attractive to explore. So perhaps I'm dodging your question a bit here, but I would return to trying very forcefully to persuade the patient that they are potentially forfeiting their chance to be cured. It is important for patients to understand that delay hurts here. That is, the longer one goes and hasn't embarked on potentially highly effective treatment, the greater the risk that the disease will have evolved further and acquired resistance to treatment that will play out in the long run and make their disease incurable. We've had very modest experience over the years with patients who make a somewhat different choice because of their reluctance to take chemotherapy and simply refuse all treatment. When that occurs, I do my very best to persuade the patient to at least come back and continue to see me. I'd rather that they not just drift away and be lost. But I also point out to them that ultimately they're going to take treatment. That is, it's going to have to be done. And what they are risking by putting it off is that they will have shifted from a very highly curable to a less curable situation, and that the treatment won't be as successful. And in addition, they will be leaving themselves open to the toxicity of multiple treatments, because of course, if one round fails, then we'll be advocating a second, potentially much more toxic treatment. So circling back to your patient, I would do my very best to persuade them that that's not a sensible decision, and that I would perhaps try to get them to speak with some patients that have received primary treatment and been cured for their limited stage disease, and actually hear from real people what the actual experience was like, because the toxicity can be rendered, I think, perhaps much less fear-inducing than they imagine it to be, and try to persuade them to stay in touch with me. But I would be unwilling to be a party to the idea of trying the experiment of just giving them a checkpoint inhibitor. I think sending them the signal that somehow or other that's acceptable is the wrong signal to send to them. And so I try to persuade them to stick with standard treatment.
Thank you. Great answer, very convincing. And I'm sure people will be very careful to play around with the curable treatment. Before we come to Dr. Rima, she will ask you the question. One question I'll take from the audience. Now, when you have this PET-guided approach of de-escalating and escalating, how would you sort of decide whether to start with ABVD and escalate to BACOP, or start with BACOP and then de-escalate to ABVD?
Well, I try to put forward the idea that what you're trying to accomplish using PET guidance is not to cure more patients. What you're doing is trying to figure out a way to reduce the toxicity. So if we now have a regimen that is brentuximab plus AVD that actually cures more patients, and I think we do, then I think that's the choice that should be paramount, picking the best recipe. When we designed the Echelon-1 trial, we thought about whether we should be using PET guidance, but at that point in time, it hadn't emerged as effective a tool as it actually is, and we decided not to integrate that into the trial. So I can't tell you what might be accomplished by using PET guidance in the management of patients who are receiving brentuximab vedotin plus AVD. But even if I had the data, I suspect all it would show is that, once again, it might be a way to reduce toxicity, not bring about cure of more patients. But you were asking about either ABVD and a potential escalation, or escalated BIACOP and a potential de-escalation. Harder for me to answer the question if I'm going to say that neither of those two approaches, ABVD or escalated BIACOP, is the best one, but rather that brentuximab vedotin plus AVD is the best one. But I suppose the best way to think of it is, if you're not going to use brentuximab vedotin plus AVD and you're going to have to choose one of those other two regimens, you want to think it through in terms of what you're going to be trying to accomplish with it. If you are doing that, I prefer the idea of starting with the milder treatment, ABVD, and escalating, simply because the majority of patients will actually march all the way through their treatment with just the ABVD. They won't ever have to have been exposed to the more toxic recipe, the escalated BIACOP. That will spare them then some of the objectionable toxicity in terms of fertility, secondary malignancies, hospitalizations, and expense attached to the escalated regimen. And you're going to get to the same place. Those two approaches are going to cure just as many patients. You're just playing around with voiding toxicity. So I guess you can hear from the way I'm answering that I'm not much of a fan of escalated BIACOP. I think it was a wonderful approach to thoroughly explore, as was done by the German Hodgkin Study Group and those that have done trials built around it subsequently. But at the end of the day, I don't think it accomplished what we wanted, which was to cure more patients at acceptable levels of toxicity.
Thank you, sir. Dr. Rima.
Thank you, sir. So you showed us the various treatment options that are now available for relapsed refractory Hodgkin lymphomas. I just wanted to know if there is any head-to-head trial that is comparing which one regimen is better than the other.
So I think you're asking me about perhaps the chemotherapy that should be used first and before the transplant. Is that what you're asking about?
Yes, sir. Yes, sir.
Yeah, so I didn't dwell upon the structure of the approach, but it is important to remember that the way things typically unfold, the patient has had primary therapy, the disease has persisted or come back, and one needs to launch into a secondary regimen. We have a variety of possibilities here, older regimens, all the way back to MOP-like regimens that might be used. And what we're doing is anticipating that the patient is going to become a candidate for high-dose chemotherapy and stem cell transplant. Much is made of the idea of choosing a regimen that's going to maximize the likelihood of a good response before the transplant is done, but I think it's unduly emphasized. The intervention that's going to cure the patient is the high-dose chemotherapy and the stem cell transplant, or perhaps the high-dose chemotherapy by itself. And so what's most important here is that you get to that. That means to me that what regimen one uses on the way is actually less important. My preference there is to stick with one that you're used to using. So if you like ESHAP, or you like DHAP, or you like any of a variety of secondary rounds of standard chemotherapy, I would just use that one. Making sure that you are using one that you're comfortable managing the toxicity of, because the key thing here is to get to the transplant. Contrary to what many experts here would recommend, is that I don't think it's so important that one have achieved a complete response before getting to the transplant. What's important is that the disease be kept under control while the plans for the transplant are made, and then that one go ahead with the high-dose chemotherapy. I think the error that sometimes gets made is to fail to get a very good response with the secondary chemotherapy and go to a tertiary or a quaternary, another round of standard dose chemotherapy, my preference is to go ahead with the high dose chemotherapy anyways. I understand that if the patient hasn't reached a complete response, the likelihood that the high dose chemotherapy will cure them is less, but I don't think that can be altered by inserting additional secondary treatments. I think that the important thing is to get on with the high dose chemotherapy. We looked at this specific question in our patients, and we found that even when patients have outright resistant disease or only have a partial response to the secondary chemotherapy, they can actually still be cured 30, 40, 50% of the time with high dose chemotherapy. So the key thing for me is don't let things delay that happening. Don't risk additional toxicities occurring that preclude the ability to deliver the high dose chemotherapy. So that's a long and roundabout way of saying I don't think it's very important which secondary treatment you choose. I think it's become increasingly fashionable to use some of the newer agents. And so I see people using combinations of older regimens like DHAP, but adding brentuximab vedotin or adding a checkpoint inhibitor. I guess I can't either urge or dissuade you from any of those approaches because, as I was just saying, I don't think it's so important. Get used to using one multi-drug standard dose chemotherapy recipe in that situation and then do that. You use it regularly. Typically 2 to 3 cycles of treatment will bring some stoppage of the progression of the disease at least, or even a potentially quite useful response, and then get on with the high dose chemotherapy, minimizing the risks associated with it, because that's the aspect of treatment that's going to be of most benefit for the patient.
Thank you, sir.
Thank you, Dr. Rima. Dr. Subhaprakash.
Sir, I have one quick question. When we go for the autologous stem cell transplantation, and we know that around 50 to 50% patients are cured by the autologous stem cell transplant itself. So which group of patient we should go for the brentuximab consolidation or maintenance? So you advocate to give brentuximab consolidation to all the patients, or you choose some particular group of patients where you give the brentuximab very selectively?
So the question is, should we be selecting patients for consolidation brentuximab, or should we be giving it to all the patients that undergo the high dose chemotherapy? And I'm a firm recommender of the second approach. Here's my reasoning. The trial that was done, the Athera trial, did attempt to focus on patients with a poorer prognosis. So there were various higher risk characteristics that were chosen. But it's important to understand that that was done not because there was any thought that those were the only patients that should receive the treatment, but simply so that the trial could be done as quickly as possible. If you concentrate on the patients with the least likelihood of a good outcome, then you'll get your answer most quickly because you will see that many more relapses occurring despite the intervention. So it was a mechanical decision to do the trial and get the answer fastest. It doesn't make any sense to me to think that a intervention, that is the consolidation brentuximab vedotin, that improves outcome for patients with poor prognosis disease would somehow or other be of no benefit to patients with better prognosis. In fact, I would think the opposite. If your likelihood of curing the disease is all the better with your high dose chemotherapy, then I would expect the brentuximab vedotin to be even more effective in that situation because you're dealing with less resistant disease. So my approach, our approach at our center, from when the results from the Athera trial became available, has been to give the brentuximab vedotin consolidation to all the patients. Think about the situation that you're dealing with. You've got a potentially curable disease. high-dose chemotherapy and stem cell transplant cures about half of the patients, as you said. If one adds brentuximab vedotin and the patient had adverse prognostic factors, we know from the Athera trial that you can eliminate about a third of the relapses that otherwise would have occurred. I think that there's a chance that if the patient didn't have an adverse prognostic factor present, that the chance of adding the brentuximab will boost improve the outcome would be even better in the good prognosis patients. And so I'm eager to see, in a situation where the patient is at risk of having a failure half of the time, I'm eager to do everything I can to maximize the likelihood that this will be the time when the patient gets cured. So I think if you've committed the patient to high-dose chemotherapy and stem cell transplant, the best thing to do is to plan on giving them consolidation brentuximab vedotin.
Thank you.
Thank you. Dr. Radhika.
Thank you, sir. Thank you for the presentation. An enlightening presentation. You have touched upon multiple newer agents in the management of advanced Hodgkin's lymphoma in your presentation. I happen to come across the usage of ibrutinib, the role of ibrutinib in advanced Hodgkin's lymphoma while going through the literature, so which you have not really highlighted in your presentation. Do you want to comment on the role of ibrutinib in advanced relapsed refractory Hodgkin's lymphoma?
Well, I think I probably should admit that you probably know more about this than I do.
I just came across when I was going through literature.
Yeah.
I would like to hear from you, like the role of ibrutinib here.
Yeah, well, I should be quick to admit that I probably don't know as much about it as I probably should. I have seen the reports that ibrutinib can have some effectiveness in this situation. I haven't seen them organized in a particularly compelling fashion to tell me that, as opposed to the variety of other agents that might be available, that it would be a better choice. Of course, it would be attractive because of its low level of toxicity and ease of administration. But I'm going to have to dodge your question a little bit and say that perhaps it's a sensible thing to explore, but phrase my answer differently. So we're thinking now then of patients that have had good primary therapy and it failed. They've had good secondary therapy built around high-dose chemotherapy, and as I was just saying, consolidation brentuximab vedotin, and that has failed. I would recommend that you have a standard approach that you take under those circumstances so that you can get hands-on personal experience with a way of treating the disease which minimizes toxicity and has some potential to successfully address the disease. If at all possible, that's the point in time definitely to enroll a patient in a clinical trial. I say that because not only might the patient benefit, but other patients will benefit from the observation that you can make and contribute to the literature. So if at all possible, try to have a clinical trial available at your center that tests something in that situation, ibrutinib or otherwise. Gain some organized information and share it with the rest of the community. If that's not available, then I would simply review what I have on the shelf, see what you have in your pharmacy and available for you to use, perhaps some of the agents that I mentioned in my lecture, or others that have had, as has ibrutinib, observation that the occasional patient benefits. Remembering that there are some agents that we don't often use in Hodgkin lymphoma, like bendamustine, that are actually quite effective, even when many other agents have failed. And so you do have available to you other agents that might be helpful in this situation. But before I turned to ibrutinib, I'd want to have thought through whether I could make any of those already modestly established agents could be available, because you're probably working in a situation where the disease is not going to be cured. you're attempting to control symptoms for as long as possible and improve the patient's quality of life. You're trying to offer high-grade palliation to the patient. And your interest there should be the combination of minimizing toxicity and maximizing effectiveness. And if, with all of that thought through, all that you have in your hands and available is ibrutinib, then an empiric trial to see what it can bring about would be, I think, an acceptable approach anyways. But it certainly wouldn't be high among the choices that I might make.
Can I ask a quick second question, sir? A small
Sure.
question. Do you, in your routine practice, the fertility preservation manual, sir, in your regular practice?
I'm sorry, I didn't understand that. Say it again, so.
Do you, in your routine practice, practice the fertility preservation manuals before starting chemotherapy?
Yes.
Practice it routinely?
No. So I think we do have adequate amounts of information to say if you're going to rely on tried and true ABVD, that two observations. First of all, it doesn't tend to have much effect on fertility. And second of all, there isn't any intervention, say an additional medication that one might give, that minimizes what modest effect it has on fertility. And there aren't any particularly attractive alternatives to employ. So fortunately, the men who take ABVD seem to go through a period of oligospermia that can last for 1 to 2 years, but is usually more brief than that, and their fertility returns. The women typically have either their menstrual cycling ceases or becomes irregular or as less dependable, but then returns to normal as a year or two goes by after the ABVD, and their fertility doesn't seem to have been impacted. The one exception to that is that older women, and I use the term older hesitatingly here, but we're talking about women in their 30s and 40s, they may experience a somewhat more premature onset of menopause after ABVD. But this is true of any chemotherapy that one might use for Hodgkin lymphoma. And so I do tend to warn them that there is a small potential that their period of continued fertility will be abbreviated by the chemotherapy that's necessary for them to take. But I don't think that there's any intervention that one can use that further reduces the likelihood of that happening. And fortunately, the very large majority of patients that we treat to cure their chemotherapy, to cure their Hodgkin lymphoma, are not going to have their fertility affected by the intervention. Finally, we don't, of course, have quite the same amount of experience with brentuximab vedotin plus AVD, but I was quite comforted by the data I shared with you about the likelihood of pregnancy occurring in both the patients or in the patient's partners after that regimen. And so I think it probably does fall into the same category of minimally impactful. And therefore, I don't think it's necessary to take any special measures to try to preserve fertility in patients treated with that regimen.
But you mentioned the percentage as 50% pregnancies. So it was not like the percentage of pregnancies, successful pregnancies was 50%, 49 or 50%. But it was not a very high percentage, what you mentioned in your slide.
I didn't explain it as carefully as I should. It wasn't a percentage, it was a number. And so all that we did was to compare, I guess if you like, we started with the assumption of what I was saying, that is that the ABVD would have no or minimal impact. And we simply compared how many pregnancies occurred in each of the two arms of the trial. So it wasn't a percentage, it was a number. And the fact that it was simply the same number or approximately equal numbers was the comfort to me. It doesn't seem to have had any more effect on the likelihood of pregnancy to have taken the experimental arm.
Thank you very much, sir. That was a great update, sir.
Dr. Gunjan.
Thank you very much, sir, for a very nice presentation. I have a question. Do you recommend adding checkpoint inhibitors with conventional salvage regimens before autologous transplant? Is there any efficacy adding checkpoint inhibitors with salvage regimens?
I don't think there's evidence at the level to say that one needs to do that or one must do that. Because as I was saying, what's going to cure the patient is the high dose chemotherapy and the stem cell transplant. So the goal of the secondary chemotherapy, the standard dose chemotherapy or chemoimmunotherapy that's being given, is to control the disease well enough that the patient can get to the transplant. So that means to me that it isn't, if you like, necessary or objectionable to insert a checkpoint inhibitor there.
Does that affect the stem cell mobilization?
Not that we know of. So the likelihood of being able to mobilize the stem cells that we want doesn't seem to be compromised by the use of the checkpoint inhibitors. But I think here it's a situation in which I would have to ask, why would one feel there's any necessity to do so? The idea here is, as I said, to control the disease, keep it from progressing, keep it from causing additional trouble that would interfere with being able to go to the high-dose chemotherapy and stem cell transplant. And we already have in hand regimens that are not as expensive and that are tried and true that will accomplish that task. So it's a situation where my preference is to simply rely on something that I've been used to doing in the past, because as I said, the money is on the high-dose chemotherapy. That's what's going to make the difference. And so what one uses as the lead into it, I think, is much less important. And so I would neither be strongly in favor of or strongly against incorporating a checkpoint inhibitor. I don't see that as an important issue. Getting on to the transplant is the important issue.
Thank you, Dr. Gunjan. Dr. Aditi.
Good evening, sir. Sir, my question is about a specific patient population of pregnant females. Your experience regarding treating them upfront as well as in relapse settings, sir. How do you tackle that issue, sir?
It's an important issue because, of course, Hodgkin lymphoma occurs in younger patients. And across the spectrum of malignancies that can occur coincident with pregnancy, it's a surprisingly common one. Probably the second, third, or fourth most common malignancy to encounter in pregnant patients. So we do need to have an approach. The first thing to concentrate on with Hodgkin lymphoma is that, fortunately, it's not a particularly rapid or aggressive disease. That is, it does change with time, but it doesn't change all that quickly. So when one encounters a patient who is pregnant and is not symptomatic, is not ill with symptoms and pregnant, often the best strategy is to simply hold off and wait for the full-term pregnancy to have been completed and the child delivered, and then embark on treatment, which of course means delaying the full staging of the patient until that point in time so that one chooses the appropriate measure to intervene with. So my first thought is to check and see, is the patient threatened, symptomatic with their disease? If not, then I would prefer observation and hope that I'm going to be able to get all the way through to term delivery. However, if symptoms occur, or if with the minimal non-invasive assessment that one can mount with ultrasonography and laboratory testing tells us that the disease is threatening in a particular way, then intervention is necessary. And there have been a variety of approaches taken here. At this point, we've had enough experience with ABVD under those circumstances to say that it appears to be relatively safe. And so if one feels the necessity to intervene, that regimen can be used. My own personal preference, however, is to shy away from the kind of toxicity that even ABVD induces. And so at our center, we give the patient single agent vinblastine. This is very well tolerated. Typically, patients can take it with no side effects that trouble them at standard doses of 6 milligrams per meter squared. I give it every few weeks so as to be able to keep the disease from progressing during the pregnancy. And then when the term delivery has occurred, embark on standard chemotherapy. The patient can no longer be staged adequately because you've, of course, modified things with the vinblastine. And so the patient is then committed to a full 6 cycles of treatment. But that's a way to minimize toxicity, get to the term delivery, and I think still get an excellent outcome in the long run for both the patient and the child that's delivered. If, however, that is not adequate to the task, and occasionally a patient won't have their disease so easily kept from progressing, or their symptoms held from worsening with the single agent vinblastine, then escalating to ABVD is the appropriate thing to do. And one then embarks on the full course of treatment. This is not a situation where I would be happy using the alternative of brentuximab vedotin plus AVD. I don't think that we have the kind of levels of information about safety to make that a sensible choice. And so if one has to go to multi-agent chemotherapy, which fortunately only occurs in a small minority of patients, then I would go with standard ABVD. So to sum that up, asymptomatic Hodgkin lymphoma discovered during pregnancy can be observed. Symptomatic disease can be treated with single agent vinblastine at intervals of 2 or 3 weeks, and the patient deliver the baby at term. And aggressive disease, which can't be controlled with that in the small minority of patients, I would treat with ABVD.
Yeah, thank you, sir.
Thank you, Aditi. Subhaprakash will come back to you after Dr. Harveen. Dr. Harveen, go ahead.
Good evening. Thank you for the lecture. Most of the questions have been I would like to discuss.
I'm sorry that I'm losing the sound, so I'm not able to hear what you're asking me.
Questions have been covered by you. I would like to discuss one of the case which came across to us in our OPD. So a patient with classical Hodgkin's lymphoma came to us post 6 cycles of ABVD and GDP, and the patient has relapsed. So how do we manage such cases?
So the patient has had ABVD, and the disease either persisted or it came back again. And then they had gemcitabine, dexamethasone, and cisplatin, and it either persisted or came back again.
Yes, sir.
I think that that's a patient that I would very strongly hope to be able to get to high-dose chemotherapy and stem cell transplant. In fact, I think that that's the only intervention with any reliable likelihood of being able to cure the disease. I would be prepared to simply move to that immediately. I wouldn't want to take any more time trying additional standard dose chemotherapy or immunotherapy regimens, but move on to what I think is the key intervention that might still be able to cure the patient and get that delivered to them. Now, that said, unfortunately, that patient only has about a 30 or 40% chance of being cured. So one needs to be realistic about what one can accomplish under those circumstances. But I don't think anything else can come anywhere near that likelihood of being able to cure the patient. And so I would be most keen to get to the high-dose chemotherapy and stem cell transplant. And an error that I think I occasionally see is attempt after attempt to control the disease with standard dose treatment, never really getting good control over it, and continuing to put off the time when the high-dose chemotherapy is given, because I think that that's further losing this already modest chance of curing the disease. So I would be most keen to get to the high-dose chemotherapy. Does that address the question adequately, or is there some other aspect you wanted me to emphasize?
No, no, sir. They benefit the patient will obtain if brentuximab is added in that case as a single line agent, if brentuximab is used for that patient, or either brentuximab or bendamustine is used as a combination for this patient.
So if I'm hearing the question correctly, you're asking, should additional treatment at standard doses, either with brentuximab vedotin or brentuximab vedotin and bendamustine, be used? No, I wouldn't do that. I think it's more important that the high-dose chemotherapy be delivered, because those other agents are not going to cure the disease. You already know that. I shouldn't be so absolute about it. That there is a tiny chance that those other agents might cure the disease, but it's actually very small. What's going to cure the disease is the high-dose chemotherapy. That's what needs to be gotten into them. The fact that they're going into the high-dose chemotherapy without a complete response is an adverse prognostic factor. It's discouraging that that's happening, but that doesn't alter the situation. The situation is one in which the final remaining reliably curative treatment is high-dose chemotherapy. That's what I want to see gotten into the patient. And I think it's actually potentially a mistake to try additional standard dose interventions, because, as I said, at best, they're simply delaying things from happening, and they are not the key that's going to be the curative intervention.
Thank you.
Thank you, Dr. Harvin. Dr. Subhaprakash.
Yeah, my question is a little different. So limited stage disease, limited stage favorable disease. Cycle 2 ABVD as given, PET scan is normal, complete metabolic response. We given 2 more cycle of the ABD, and the end of treatment PET is negative. So do you advocate any role of radiotherapy here, ISRT, or just complete the treatment?
Okay, I think I have the whole question in mind here. So the situation is one in which the patient has limited stage disease. So let's be clear what that is. So limited stage disease is either stage 1 or 2, without B symptoms and without bulky disease. So, so that's minimal tumor burden type of disease. I think that the standard that we've evolved to here is to give that patient at least 2 or 3 cycles of ABVD. And I'm going to come back to that in a moment, but let's say we'll give them 2 or 3 cycles of standard treatment. If they become PET negative at that point, at our center, we give a 4th course, or if they've only had 2, we give 2 more courses. So a total of 4 courses of the ABVD, and we stop. No radiotherapy. That is, we've been able to get the patient to a complete metabolic response with a brief course of ABVD. If the patient has persistent disease, then I'm happy to switch to the alternative, potentially curative intervention of radiation. And the radiation that I would use would be involved nodal irradiation. You just have to irradiate the site of where the disease is persisting. And when one does that, about 80% of the patients will be cured. If that all fails, then I have a patient who has disease which has persisted despite ABVD and some radiation, and then I'm happy to move on to high-dose chemotherapy and a stem cell transplant. So I don't think radiation is necessary for patients that have had a complete metabolic response to a brief course of ABVD. And I say that based on the RAPID trial and the other trials that have been done to address this patient population. Now, the objection that I then hear is, oh, well, the relapse rate will be higher in patients that don't get any radiotherapy. That is true. However, the relapse rate is not very much higher. And so one needs to step back and think, what can you accomplish here? Well, if the patient is managed without radiation after having had a complete metabolic response, the relapse rate is modestly higher, perhaps 3 or 4% higher. That translates into what I would focus on as a number needed to treat. So we can see that most simply by thinking, let's do a thought experiment. 25 patients come to you with limited stage disease, and you treat them with ABVD and radiotherapy. Of the 25, you will cure one more patient than if you follow the regimen or the approach I was just mentioning, that is only giving radiotherapy to those who have PET positivity. So you've got 25 patients, 24 of whom are going to be cured whatever approach you take. One more of them is going to be cured if you add radiotherapy for all of them. And now you have to have irradiated 25 people to avoid one relapse. And remember, in the long run, the same number of patients are going to be cured. The same overall survival is going to result. I don't think that it justifies irradiating 25 young people to avoid one relapse when ultimately you're going to cure the same number of people in the long run. So my preference is to accept the very modestly higher relapse rate when one follows the PET guidance here, and be thankful for all of the toxicity that I've avoided.
Just 1 minute, one question. When you use 2 cycles of ABVD and then you are PET negative, so then you continue 2 more cycles of ABVD or AVD in limited stage disease?
Oh, I see. I'm sorry. That's an interesting question. So we learned from the Rathel trial that if you've had 2 cycles of ABVD, including bleomycin, then you seem to have gained everything you can gain from the bleomycin. Now, it's possible it didn't actually contribute anything. We don't know that. But we do know from the advanced stage trial, the Rathel trial, that after 2 cycles of ABVD, if you've gotten to a complete metabolic response, there's nothing added by continuing to give bleomycin. I'm happy to extend that to the patients with limited stage disease. So if you give 2 cycles of ABVD and the patient has a complete metabolic response, they've gotten all the benefit they're ever going to get, if any, from bleomycin. It no longer needs to be continued. At our center, we then give 2 cycles of AVD. If you more specifically follow the approach that was taken in the RAPID trial, they gave 3 cycles of ABVD and then made the decision about the PET scan, with using the PET scan to guide treatment. And they stopped treatment if the patient had a complete metabolic response. So there's no bleomycin involved because there's no more treatment at all. I like the approach of 2 cycles and make a decision, and you can drop the bleomycin beyond that point and complete treatment with 2 cycles of ABD if the PET has become negative. Does that address your question?
Thanks a lot.
Good.
Thank you, Sivaprakash. One last question. What's the place of allo transplant?
Someone always asks me about that. I guess the approach that I think is the most sensible is to choose the very best recipe you can for the patient up front. As I've said, that would now be brentuximab vedotin plus AVD. If that fails to cure the disease, then something else to be followed quickly by planned, for all the patients, high-dose chemotherapy and a stem cell transplant, autologous, and consolidation brentuximab vedotin. And if despite that, the disease comes back again, I think there are a number of different considerations that come into play. Allogeneic transplant can be undertaken under those circumstances, and it is possible that it will cure the disease. Unfortunately, it doesn't do that very often. And so if the stars align, if everything falls in place, telling me that it's a potentially promising approach, I'm willing to consider it. But by that, I mean they have a perfect donor. They have a donor that you have high level of confidence they're going to be able to tolerate the transplant from. The patient is otherwise free of organ compromise, so nothing else is wrong. Their kidneys, their liver, their lungs, their heart, everything's working well. And finally, there have been reasonable intervals of disease control. So if the patient has rapidly gone from failure of ABVD, then failure of high-dose chemotherapy, and all that's happened in a year or two, I don't think allotransplant is going to rescue that patient. If the patient has had relatively longer intervals measured out in years between the recipes, and it still has not been cured, and the donor is ideal, and the patient doesn't have organ compromise, then I think it's potentially a reasonable alternative to consider. The challenge for me here is that there are two ways that allogeneic transplant can fail. The first, of course, is to not cure the disease. That's a clear-cut failure. But the other is for it to cure the disease, but leave the patient permanently and prolongedly ill with the consequences of graft versus host disease, which is a miserable outcome for the patient. And so against the idea of the allotransplant is all of the potential for it to fail or prove to be very toxic in the long run. If you can minimize the likelihood of that happening, then I think it's at least a sensible thing to consider. Finally, even when everything lines up perfectly like that and the patient does tolerate it well, the chance of actually curing the disease with the allotransplant is probably only about 20%. So you do have to go in, the patient has to go into this with their eyes open and realize that the odds are still stacked against them, and 80% likelihood it's going to fail or work and cause them to be miserable. And so without you think that all through, yes, it's an alternative for a small number of patients, but they don't come along very often.
Thank you so much, sir. You have tremendous amount of patience. You handle the questions very, very spatially and very tactfully. A lot of young brigade was there, and they had questions which might have looked very preliminary to you and repetitive to you, but you answered them very smartly and conveyed your points very emphatically. Very impressive. Thank you so much, sir, for sparing so much time and educating us. And a lot of people have been around listening to you today. As I mentioned, from 20 plus countries. A lot of them are very young people. I think it will make a huge impact on their quality of practice, type of practice, make their thoughts very clear-cut, and the approach to the patient care will improve. Ultimately, the patient will be benefited. Thank you so much, sir, today.
Well, thank you very much. It's a pleasure to have a chance to speak with you, and I hope that my comments have been helpful.
And thanks to all the people who assembled here to ask questions, listen to Professor, all the audience, our sponsors, as well as the event management team. And now I hand over to Mr. Ashish Kumar for the official vote of thanks.
Thank you, sir. And thank you, Dr. Connors. We at Zydus sincerely thank MNG and Dr. M.B. Agrawal for giving us this opportunity for supporting today's webinar. I thank Dr. Connors for his great session today and through his session highlighting the recent updates in Hodgkin's lymphoma. And it is very clear from his session that a lot of development is ongoing to improve outcomes further in the near future, with the long-term follow-up data from the studies involving brentuximab vedotin and checkpoint inhibitors to be out, which have shown promise. A very, very insightful session, as Dr. M. Agrawal said. I would also like to share with Dr. Connors that very soon in India, we will have accessible options of brentuximab vedotin and checkpoint inhibitors. So I'm sure if this data comes more promising, India would be benefited from it. So thank you, sir, for answering so many questions so patiently, as Dr. M. Agrawal said. Your time today was definitely very, very valued for everybody who heard your session. Thanks to all the eminent faculty for a wonderful discussion, and not to forget our respected virtual delegates who joined us not just from India, but across the globe. I once again thank Professor Dr. M. Agrawal for his untiring efforts to create such platforms to improve hematology care in our country and now even beyond India as well. Thank you, everyone. Good night for now, and take care, all of you.
Thank you, sir. Bye-bye.
Thank you.
Thank you, Ashish.
Thank you.